So we're going to continue on chapter 10. This is our third part of the kidney chapter. It's so long, there's so much information, but we're going to finish it up this weekend. And let's talk about trauma with the kidneys. That's going to be our first thing we kind of talk about. So you can have trauma to the renal capsule or parenchymal from like a blunt trauma, or you can have some vascular trauma that um, can cause hematomas, infarctions, and pseudoaneurysms. So, renal injuries usually result from blunt trauma or a penetrating trauma, blunt trauma like a car accident or like a punch to the kidneys, penetrating trauma like a knife, or secondary to operative intervention. CT is probably the most frequent because you can get so much information from that. Um, Sonography provides a real quick time portable evaluation of the kidneys, but seems like CT is used most likely. So, reproducible linear absence of echoes seen in the area of a traumatized kidney suggests a renal fracture. Um, and then focal areas of the internal hemorrhage and edema are hypoechoic. Um, so, with sonography, it demonstrates either like an anechoic or hypoechoic region of the kidney that's fractured, almost looks like a with bleeding into the retroperitoneal space. So it almost looks like a mass. And hematomas may result from, a blunt trauma or, a car accident or something, but the spontaneous hemorrhage into the subscapular and paranephric spaces are rare. Sonography is very sensitive to presence of hemorrhage and hematoma. Depending on the age of the bleed, the hematomas have varying echo patterns, and this is not just with kidneys; it's any kind of bleed that you're going to get. As it gets older, the echo texture changes for it. So acute hematomas appear echogenic or even hyperechoic, and can mimic a solid mass. But gradually, as there becomes clot, it reveals a complex heterogeneous pattern of internal echogenic, hypoechoic, and anechoic areas. And then as it keeps going down, it goes to more anechoic patterns. So with kidney hematomas, if it's a new bleed, it will appear bright. And as it becomes older, it appears darker. Chronic hematomas may become calcified and produce characteristic acoustic shadows. To rule out the active bleeding process, perform color Doppler over hemorrhage site to determine if blood flow exists. If it's still existing, it's probably active bleed. So we remember the capsule of the kidney that we talked about. So a subcapsular hematoma is going to lie between the renal cortex and the capsule. With sonography in acute stage, subscapular hematomas are difficult to visualize as they may be isoechoic to the kidney. I think that's why they like to use CT. It seems to be more sensitive, this kind of stuff. Here is an image on A of a subscapular blunt trauma. And so you can see like the cap where the arrows are, the capsule of the kidney is irregular up on the superior pole. And then when they put power Doppler on, there wasn't much blood flow over there, which means it's a hematoma. Here's another really good one. It's really what it kind of looks like. So 24-year-old patient with a history of blunt abdominal trauma. Long image of the left chemist kidney demonstrates a hypoechoic collection anterior to the kidney. Collection lies between echogenic renal capsule and cortex. Hematoma follows the kidney contour. So that one's pretty easy to see that there's some kind of fluid in between the capsule and the kidney. Renal infarctions are caused by obstruction of blood supply or blood drainage by occlusion or stenosis of the vessel. Immediately after the infarction, sonography may not be able to detect it, but within 24 hours of arterial occlusion, the infarcted area will become hypoechoic. Usually caused by pseudoaneurysms are usually caused by penetrating trauma like a gun or a knife. Appears as anechoic spaces similar to renal cysts, but most are associated with the AV and arteriovenous fistula and can be identified with Doppler or color Doppler. So the interesting thing about pseudoaneurysms is like the to-fro pattern. And so you will learn more about that in vascular. So for vascular trauma, these are the kind of things: a hematoma, infarction, pseudoaneurysm. Maybe just know what causes each one of these. Sonographic features are very variable on the hematoma, but you're probably going to get a regular thick wall. So I would just study maybe lesions and sonographic features. Okay, we're going to go to acute infection and inflammatory diseases. So an upper urinary tract infection can cause significant morbidity and are second only to respiratory infections in prevalence. Bacterial infections may remain asymptomatic or localized to the bladder, but carry the potential to spread to the kidneys. And bacteria send the urinary tract through the urethra or along the lymphatics. Incidence of the infection greatest in 15 to 24 years of age in women. In men, urethral length and antibacterial properties of prostatic fluid provide some protection until around age 50. So usually CT is the imaging modality of choice for acute renal infections. But sonography is less sensitive with acute renal pathology. Urosepsis represents true urological emergency and requires urgent drainage. So with acute pyelonephritis, I actually had this when I was 21. I had a bladder infection pretty bad. I started taking my antibiotics, but then it was like in December, so I started getting really bad flu symptoms. And so I went to the doctor and he's like, I think you just have a flu on top of, bladder infection. And I couldn't keep my medicine down. And I was kind of still living with my mom, and she was spraying me with Lysol everywhere. And I stayed in my room for 2 days, just very, very sick. And eventually my fever went up to like 104, 105. And they're like, we just got to get you into the ER. So we go to the ER and they are looking around and they hit my kidneys, and the pain, of them touching my kidneys was just unbearable. And they're like, pretty sure you have a kidney infection. So I went over with ambulance and I went to Wesley and I stayed there for 3 days, and I was just on the floor, but my fever got so bad and I was shaking so bad that they took me to ICU. So then I was in ICU for 3 days over New Year's Eve. And they tried all sorts of antibiotics and couldn't figure out what one to help me. So they were getting worried about sepsis by that time. And finally, an infectious disease doctor came in and was able to diagnose me. And then I started feeling so much better once we got the right antibiotics going in there. But I was like, that was very serious and very terrifying, like that a bladder infection could lead to all that. Um, and this whole time, I don't believe I ever had any imaging, like either CT or ultrasound, because I think they were just going off my symptoms, and blood work. But I know now that if I have any symptoms of any kind of UTI, I go get it treated very fast because I do not want to go through that again. So nowadays they might be different. Granted, that was like quite a ways, like more than 15 years ago. Um, and maybe while I was sleeping, I had a exam. I'm not sure. Like I don't think I had anything, but I definitely would have remembered if I had an ultrasound because that's what I was wanting to go into at the time. Um, but they did scan my kidneys, like my friends at Newman, because I was in the X-ray program at the time. And they did scan my kidneys, and honestly, my right kidney, which was the one that was infected, just looked a little bit maybe larger at the time after I got out of school or out of the hospital. But now when looking at my kidneys now, they really improved, and you would never know that I had this horrible infection in it. I heard that sometimes with pyelonephritis, if you would have scanned me in the ICU, you probably would have saw that I had like some swelling in the cortex of my kidney and maybe potentially a little bit of renal enlargement. But honestly, it's kind of um, just vague on what it's going to look like. Here's a picture of it. Um, Kind of this is like the right kidney. And you can tell like it's indistinct borders. It just doesn't look clear. It looks kind of nasty. Um, and this is like a swollen hypoechoic heterogeneous right kidney. That's probably what mine would have looked like when I was like in the ICU and really sick. You can also have this word just always gets me emphysema metis, emphysematous pyelonephritis, EPN, and it's generally considered a life-threatening disease with a mortality rate as high as 30 to 40%. So that's pretty crazy. Um, it's most commonly caused by E. coli, and it's treated with nephrectomy if no response to antibiotic treatment due to renal ischemia. So these are the two different kinds. So acute pyelonephritis, which I had, and this crazy kind from E. coli, which could make you really sick. And this is kind of the appearance of, like, I would say, probably more likely to have a swelling and the parenchyma just be off. And with this emphysema pyelonephritis, it's going to be like unilateral hyperechoic foci or gas accumulation in the renal parenchyma. This is kind of what gas, you remember, ultrasound can't see through it. So you're going to have like shadowing, dirty shadowing afterwards. Chronic atrophic pyelonephritis is a chronic progressive disorder with unilateral or bilateral renal scarring associated with pathological involvement of calyces in pelvis. It results from incurrent infections, superimposed or diffused, or localized obstruction lesions or vesicoureteral reflux. Chronic atrophic pyelonephritis is a really significant cause of renal failure. It's responsible for 25% of renal insufficiencies. So basically, it's like like chronic kidney infections. I'm just going to say XPG for this. It's a real rare type of chronic atrophic pyelonephritis, and it's characterized by replacement of normal renal parenchyma with lipid-laden foamy macrophages. Most common predisposing factors are chronic infection and obstruction of the ureter-pelvic junction, generally from a Staghorn calculus. So, XPG is associated with Staghorn calculus, if you remember from previous studies. So, what does it look like? You're going to have distended calyces, compromised medullary perfusion, leading to papillary necrosis. Pus-filled dilated calyces may be predominant, or kidney may be replaced with this kind of tissue. 75% have a renal calculi, possibly the Staghorn, which you might have a question on your test, what kind of infection is associated with a Staghorn calculus, and it would be this one. Don't worry, I won't make you spell it out. They'll have calculi, renal enlargement, and lack of renal function. Patient's history and sonography and CT appearance are consistent with XGP. The CT is multiply the right kidney. Isn't looking very hot. Renal and perinephric abscess. Acute or chronic abscesses are a septic condition that produce unilateral flank pain, chills, fever, point of tenderness, and costovertebral angle. An abscess in the renal cortex may result from a union of several small abscesses and may rupture into the collecting system through the capsule, causing a perirenal abscess, a pus collection in the space between the kidney and the renal fascia. Abscesses are most often confined by fascia and may extend into several directions. Perirenal abscess immobilizes kidney so that a deep inspiration or expiration do not produce the normal exertion of the kidney organ, and displacement is strikingly abnormal. The abscesses look nasty on anything, but they're going to look like heterogeneous, pus filled, irregular walls. Just looks sick. Here's a smaller one. Pyonephrosis is the presence of pus material in dilated, often obstructive renal collecting systems. When suspected, sonography is the imaging procedure of choice. Minimal to marked hydronephrosis, thickness of the renal cortex, and inflammatory extension outside the kidney can be evaluated. Sono findings are variable. Presence of tissue and cellular debris produce low-level echoes in dilated collecting system. Distinguishing pyonephrosis from other causes of urosepsis is important. The long image of these two patients would diagnose pyonephrosis. So this is like a localization in A of the pus-filled mass. And B, it's affecting the entire kidney. And you can see like how the medulla looks indistinct. Fungal infections. The most common cause of fungal UTI is a Candida albicans, which is like a yeast infection, at risk premature infants with long-term indwelling catheters, and adult patients with diabetes and cancer, indwelling foreign bodies, chronic illnesses, AIDS. The infection may be limited to upper or lower urinary tract and may be unilateral, bilateral. Sonography appearance of fungal infections may be similar or identical to the acute pyelonephritis. So it's really, really hard to know. That's why you have to also have like lab and other imaging modalities to kind of pinpoint. You can get a fungal ball, which is pretty nasty. Fungal balls appear hypercoic, non-shadowy masses. Man, this kid is, or this person's really sick because this whole echogenic thing with all these little dots, um, that's a patient has like pneumocytosis, gyro, gyros, gyrovesi pneumonia. Man, these, and then this arrow on C is a fungal ball, fungal balls there. But you can see that these kidneys, they don't look good. Here is the difference between pyonephrosis, which is pus, and fungal infections a little bit, and what their sono features are Schistosomiasis. We also talked about this in the liver. All you need to know is that it's from parasitic worms residing in fresh water in the form of larvae in developing countries. And yes, the larva can penetrate and go to the kidneys too, not just the liver. You can also get renal tuberculosis if you've had an infection of tuberculosis. Usually the renal TB does not manifest itself until like 10 to 20 years later. Usually it's good with antibiotic therapy though. This is a patient with renal tuberculosis. The calyces are dilated. Malakoplakia is another inflammatory disease from E. coli. Usually it only affects one kidney. You're going to have poorly defined masses that distort and compress in central echo complex. Though you can also have medical renal diseases. So the renal pathology involves interrelated nephron, vascular, and interstitial tissues. Hallmark of a parenchymal renal disease is a diffuse increase in echogenicity throughout the parenchyma of both kidneys. So if the parenchyma get more echogenic, they probably have like some kind of chronic renal disease. This is renal cortical disease. And you can see hydronephrosis. You can also see how small that kidney is compared to the liver. Kidney disease and renal failure are the fourth leading cause of death in an HIV positive person. Pre-renal failure may be due to hydration. Post-renal failure may be due to hydronephrosis or AIDS-related nephropathy or nephrotoxic drug use. With AIDS-related stuff, you can also get that pneumocytosis gyrovesi that I had that picture of where it was. Here, let me show you. This one that can occur in AIDS. They just have their immune systems down. Diabetic nephropathy. It's the leading cause of chronic kidney disease, chronic renal failure, and cause of diabetic morbidity and mortality. So, in the diabetic patient, renal disease is defined clinically as persistent proteinuria, retinopathy, elevated blood pressure, but without UTI or other renal disease. Elevated RIs and pulsality indexes correlated with progression in nephropathy and correlated with the list of other parameters used to predict diabetic. So they do like creatinine clearance, systolic and diastolic blood pressure, and patient's age. But this is a 46-year-old man with end-stage renal failure and a long history of diabetes. And diabetes can really just like kick your kidney's little booty. So it's so important if diagnosed with diabetes to make sure that you are doing all the things, watching your blood sugar, exercising, insulin control, taking your medication, to prolong the life of your kidneys. Papillary necrosis affect renal medulla and involves soft papillae or calcifications in renal medullary pyramids. This is a 70-year-old woman is being evaluated sonographically for renal insufficiency and was diagnosed with papillary necrosis. Lupus can affect your kidneys. It has a female to male ratio of 9-1. So here are just some of the diseases that can affect the kidneys. So just maybe like go over those and just know not necessarily what the sono features are, but just if asked true or false, can AIDS affect your kidneys? You can say true. Okay, real quick, renal injury. It's the inability of the kidneys to remove accumulated metabolites from the blood. Situation causes alterations in electrolyte, acid base, water balance, and accumulation of substances that normally are completed excreted. Renal injury is classified as acute, develops over days and weeks, chronic, spans months and years. Acute or chronic is rapid reduction in renal function in patients with previously stable chronic renal disease. So you've heard of people that have like acute renal failure or chronic renal failure. Acute kidney injury is replacing the former term of acute renal failure. Chronic kidney disease replaces formal term of chronic renal failure. So we kind of changed the game on what we're calling it now. So acute kidney injury affects approximately 10,000 people and the mortality rate is 60%. There's three major categories: pre-renal, intrarenal, and post-renal. It's potentially reversible. If untreated, though, severe reduction in glomerular filtration rate causes irreversible damage. So pre-renal is like renal hypoperfusion secondary to systemic cause. So like if you're just having trouble getting blood or what's needed to the kidneys. So like heart failure or septicemia or salt depletion or hypotension or hypovolemia. Intrarenal is a result of a medical disease. And post-renal is a result of outflow obstruction. So acute bilateral renal thrombosis or acute urinary tract obstruction. So acute kidney injury, long sonogram plate displays an echogenic, normal sized right kidney. Increased cortical echogenicity is an indicator of diffuse renal prequel disease, but is not useful in distinguishing between acute and chronic cause. So both kidneys and an older lady with it. Chronic kidney disease is a reversible condition characterized by diminished function of nephrons, resulting in decreased glomerular filtration rate, renal blood flow, tubular function, resorptive capability. Sonic sonography findings are not disease specific with no correlation between the type of severity of glomerular disease. But I will say that with chronic kidney disease, if you go in there knowing that, you're looking for very small echogenic kidneys, which are kind of hard to see. You're not going to get your nice full kidneys. You're going to get like these small, like shriveled up kidneys. These are some reasons why you could get chronic kidney failure. These are what they look like. They're so hard to see. Like they just kind of blend in with, the bowel, especially like the left kidney. It's kind of like, is that it? Like if I'm having trouble finding a kidney and they know they have both of them, I'm pretty much like, you probably have some kind of chronic kidney disease. So dialysis patients, blood from the artery moves through an artificial kidney unit designed to assume the physiological function of the nephrons, after which the blood is returned to a vein. Sonography is useful for monitoring the kidneys of patients who are receiving long-term hemodialysis. Many patients with chronic kidney disease receive hemodialysis, develop bilateral cystic disease. 43% of patients on dialysis for 3 years, greater than 79 of patients on dialysis are for 5 years, and 90% of patients on it for 10 years. Kidneys may appear somewhat small and echogenic, and cysts are seen throughout parenchyma. That's what it looks like. The other thing I have noticed with like chronic kidney disease patients is like the cortex is really thin. Um, So that might be another reason or another thing that you can look at. Plus, some cysts are developed more echogenic, smaller. So renal tumors occur about 7% of patients with acquired cystic disease. Tumors are usually less than 2 centimeters. Neoplasms may be multiple or bilateral. Oh, and I guess that's it. So again, sonography is like less expensive, detects most renal cell cancers before they metastasize. But you got to be careful because sometimes with these 2 centimeter masses, they're a little bit more um, harder to see. So you want to make sure that you're always taking your time um, when you're scanning kidneys. But yeah, oh, we made it through. That was like so much information, like 300 slides worth of information. But I hope that you guys have a good day and we'll see you later.